I would know about the which of these make the anterior wall of the inguinal canal. Please, one.
External oblique.
External oblique what?
Neurosis.
Upper nerve.
No.
Upper nerve. If you say external oblique, muscle, upper nerve. What? Which part? So, upper nerve of external oblique. Two. Is there another one that covered the anterior wall of the inguinal canal?
Muscle fiber.
Muscle fiber.
Look. Then when you look, you can answer. If you look at the floor or internal what?
Muscle fiber of internal.
Internal oblique muscles. Yes. So number two, muscles of internal oblique. Is there anyone who is still covered the anterior wall of the inguinal canal?
No.
Skin and superficial, facial, but because we are discussing about the muscles, but upper nerves and muscle fibers, these two. And I don't know about the roof of the inguinal canal. What do we have? Which one cover the roof of the
1/3 lateral transfer.
Transfer.
Transfer abdomen.
Excellent. Because if you push your finger through this orifice, then goes behind this, okay, and reach here, and finally goes to the deep ring. So this and this cover the upper part. We say roof made by internal oblique plus external oblique muscle fibers. It's so clear, yes? These two make the roof. When I say roof, it means when I push my finger and trying to pull up, it should be what? A strong between something. The muscle fibers not letting it my finger going up. Okay? So this make the upper or surface roof. Next one, we expected a canal had, I said, this canal is above of the inguinal ligament. Again, you should be attention about the lateral and middle 1/3 because the deep ring is here, yes? So it is a canal above the medial side of the inguinal ligament above, and medial side its length is 4 centimeters. So if I cross my finger through this canal and then push down, it reaches to the floor. Which one make the floor of the inguinal canal? Excellent. This one is the floor. So we say the floor is by inguinal ligament. What about the posterior wall? Which one make the posterior wall? Why you say peritoneum?
Because
in all of this till here, when we are discussing about the anterior wall, you attend your attention back to this and this. When you say roof, these two, floor, this, posterior wall. So here, easily you can see the posterior wall of the inguinal. But this one is not the posterior wall. It's a part that most behind of the posterior wall. Exactly, posterior wall made by
Transfer fascia.
transverse fascia. Just made by
Transfer fascia.
transverse fascia. Yes.
the transverse abdominis is not present at the roof.
Transverse muscle.
Yeah.
Oh, that's abdomen. Number 3.
Muscle or transverse fascia.
Abdominis muscle.
Exactly. And she mentioned this.
You did
Internal,
mention this.
oblique, and transverse. Both of them make the roof.
You just use
You-
internal and external.
Just oblique.
Plus. The plus. Transverse, I mean. Sorry, yes, you're right. Transverse. You mean here should be T, yes? Transverse, yes. Transverse. Right, thank you. Inguinal canal is a canal with two orifices. Superficial ring under the skin, deep ring at the transverse fascia, and at the border between lateral 1/3 and
Middle.
medial 1/3. Yes? Attention to the distance between the superficial ring and deep ring. This should be made a canal, and each canal should have the roof, floor, anterior one and posterior one. But something it may be cause you thinking about a problem that I'm sure you can imagine the problem by the looking to the inguinal canal. For example, look to the posterior wall. Exactly, just we say posterior wall made by transverse. When we say transverse fascia, it means it's a loose connective tissue. So if we coughing or doing something by force, I mean the internal abdominal pressure being higher or rise, easily the intestine can push this fascia and reach to this, or destroy the fascia and directly come to the inguinal canal. Am I right? Yes. So there are some points that reinforce the posterior wall. If not being this, I mean, if we don't have these reinforcement elements, easily when we cough, sneezing, or intestine goes through the inguinal canal, reach to the inguinal canal and reach to the surface. Look here, please, carefully. The muscle fibers of the transverse and internal, this and this, both of them join to each other. This and this join to each other and attach to the pubic crest. Imagine, please, look carefully. Look here, please. Look here. Here we have pubic crest, obturator foramen, and inguinal ligament. Yes? Yes? Inguinal ligament. And here, there was a point that I mentioned you. I told you above of the pubic crest, here, there is a defect that now we know the name is superficial foramen of inguinal canal. Yes? These two muscles, external, internal oblique and transverse, both of them curved and attached to the pubic crest. Posterior than these two muscles are in front or posterior than external oblique?
Posterior.
Posterior. So when I say these two attach here, it means they are posterior than the superficial ring. Am I right? These two muscle fibers, when joined to each other, they call conjoint tendon. So conjoint tendon is a mixture of the internal oblique and transverse. That these two join to each other and reinforce which part?
Facial.
When we say posterior to the superficial ring, it means the posterior wall. Here, look here, is to reinforce this part. Am I right? Yes? So, here, by the attachment of these two, I mean conjoint tendon to the pubic crest, reinforce the posterior wall here. So, there is a possibility for the intestine that pierce this part. Yes? This part between this and this. Is there this possibility? Yes. But here reinforced by what? Conjoint tendon. So again, another point is here. Here and here. These two arcs are here and named arcuate line. Arcuate line. Okay? What make these arcuate line the arc flexure of the upper nerves of transverse and internal oblique? Here I mentioned that between the umbilicus and septal pubic there is a defect at the midline. Okay? Below this make an arcuate line. Arcuate line. No, we should be aware about the formation of arcuate line. Arcuate line is a reflection of upper nerve for transverse and these two, because they reflected upon the approach of these two, find a reflection. Because of this, here we have arcuate line. Arcuate line medially attached to the midline, laterally goes down, look here, and attached to the inguinal ligament exactly medial than deep ring. The address is here. It's so clear, yes? So arcuate line was a reflection of the upper nerves for transverse and internal oblique. Medially, it attached to the midline and take part to the linea, making linea alba. Laterally, again, it's become condensed and make a ligament that attached to inguinal ligament exactly medial than the deep ring. When we say medial than the deep ring, it means it's at the posterior wall of the inguinal canal or it is out of the inguinal canal.
Posterior.
It's inside of the canal, I mean at the level of the canal, or it is out of the canal. It's part of the canal because it's medial than deep ring. Yes? Everything that we have here is part of the canal. And that part is out of the canal. Inguinal canal was a canal 4 centimeters from the superficial ring to the deep ring. So when we say deep ring, medial than deep ring, we just pointing to the inguinal canal. And this reinforcement make powerful the posterior wall of the inguinal canal. I mean the transverse fascia being thickened here, and this one again has a special name. Hessel-Bach ligament. What is the Hessel-Bach ligament? Is a thickness in the transverse fascia that starting from the lateral edge of the arcuate line. Arcuate line and Hasselbalch. Please review. Review, I have question, I ask you then. Discuss 2 by 2.
هذا يسمى شنو هذا بالداخل محسوب محسوب على الداخل الميديالي
Yes, then me after this.
هاي التجاوز مال ترانسفير
Okay, let's do review. Please do. Ask the question.
Can you please repeat Hasselbalch measurement?
Hasselbalch measurement? Which part I should repeat?
It is the thickness of this mass.
It is a thickness in. Is a thickness in
Lateral part.
transverse fascia.
And
Just transverse fascia being thick at the lateral edge of the arcuate line that reach to the inguinal, as you can see here, yes, attached to the inguinal ligament, medial, then the deep ring. It's very important. We should be aware about this. Yes? Yes, you ask a question.
The location of arcuate line is transverse fascia.
The origin,
No, the location of arcuate line.
the location is between the, you mean, where is the exact location? It's back something, it's maybe, I think you said about the origin of this. If you say the exact position, it not means that it originates at the transverse fascia. It's reflection. Arcuate line is reflection of aponeurosis of
second and third.
transverse and internal. When the transverse and internal reach to the midline and make this arcuate line, this curved line, laterally the transverse fascia from this part being fine thickness and then attached to the inguinal ligament. Yes? No? Which part is not clear?
The internal and transverse abdominis, they make the conjoint tendon, not the arcuate line.
Yes, they can do two things, separate things.
So
The
the
muscle, the most inferior muscle fibers that curved make the conjoint tendon.
So the
And the defect, they have two defects, yes? And the defect that they find between the umbilicus and symphysis pubic make the curved line, okay? Curved line. But this curved line laterally join to a thickness of the transverse fascia and make Hasselbalch.
So the conjoint tendon and the arcuate line are two different, separate things.
They can be separate from each other. Yes, they can be different, separate part, because Hesselbach ligament is a condensation of the transverse fascia, not belong to the aponeurosis. Yes, condensation of the transverse fascia. Transverse fascia being fine thickness, I mean, yes, being reinforced by joining the collection of these connective tissue to each other at this point. There is a point that it maybe you misunderstand. Back to this, that fascia transversalis in some parts in our body, I mean in the pelvic fossa, it can be the origin of the muscle. Origin of the muscle, this connective tissue, loose connective tissue. Yes, I said this is the loose connective tissue, but when it reaches to the pelvic, it becomes origin of the pelvic diaphragm. Pelvic diaphragm laterally attached to the wall of the pelvic at this point, that it's back to the fascia transversal. So yes, it can be reinforced and make extra part. As I mentioned here, the Hesselbach ligament. Still, there is a point in the posterior wall that it may be the intestine easily pierce, separate the posterior wall and directly reach to the inguinal canal. What I say directly, yes, directly, indirect. Direct, indirect. I say, still there is a point. Can you show me the point that still is weakness and it may be the intestine pierce this and comes inside?
The transverse superficial. Between them. Between
Could you
Hesselbach.
show? Yes, thank you. Excellent. Yes. No, just yes. It's so. Yes, thank you. It's so clear that between what was this and what was this? Hesselbach ligament. Between Hesselbach and conjoint tendon, as he showed here, still there is a defect like this. Not defect, weakness. Yes? It means that the intestine behind of this and then here can by force, I mean if you have chronic sneezing, coughing, or in old people, because weakness of these muscles, it may be the intestine pierce this part and then pierce this one, directly come to the inguinal canal. Yes? So we say direct herniation. We say what? Direct herniation in inguinal canal. Direct herniation in inguinal canal. In which part?
Between the Hesselbach ligament and conjunct tendon.
Can you tell me about the base of this triangle? I draw a triangle, yes?
Yes.
Lateral wall, Hesselbach medial wall, and base. So this triangle, this is triangle. This triangle make Hesselbach triangle. So Hesselbach triangle is a weakness at the posterior wall that all of us have this defect, and it may be some parts of our intestine pierce this one and directly reach to the inguinal canal. Direct. Indirect, when happen? What do you think if I say indirect herniation? When indirect herniation happens?
When there's something wrong with Hasselbach triangle. The height.
If someone, look carefully, if someone open the door and come inside, I say, if someone by some instrument destroy this wall and come inside, we say directly come inside. Directly come inside. It means destroy this wall. Direct. By bulldozer, destroy this wall and come inside. Direct. But if someone open the door and come inside, open the door and come inside, we say indirectly. Just there is some contrast. Okay, it's me. I mean it's not similar that we think in our mind. Direct, come direct. But I say if someone destroy these balance, come inside, we say directly come inside. Yes, for inguinal herniation, there is these 2 points. Direct herniation, when you as a surgeon open the skin here and see that the intestine comes inside through this triangle, you say it is direct herniation. If in someone through this hip ring, some intestine come inside to the inguinal canal, then you say indirectly. What do you think? When it happens? When it happens? In direct herniation, as I mentioned, in old people and in someone who has loose muscles, weak muscle, it happens. Which one? Direct. Indirect happen in
Fetal.
at the birth, time of the birth, because at the time of the birth, this orifice still is open, because something that I will mention in near future, that especially in the male boy, this orifice is still not covered or not completed, so it may be intestine goes through this ring, hip ring, and reach to the testis, for example, to the scrotum. And or sometimes there are some liquids. Have you ever heard hydrocele? Hydrocele is a problem like this. Hydrocele. I mean the liquid that we have inside of the peritoneal cavity goes through this orifice and reach to the scrotum. It may be in kid, baby, you find that the scrotum being filled by water, by cells that we have inside of the abdominal cavity. Yes? Direct, indirect. Direct. Directly through the triangle, the Hasselbach triangle. Don't forget, still, I said conjoint tendon number 1 and Hasselbach number 2. Still, there is one reinforcement that reinforce the superficial ring. Here, look here. This was what was this? Yes. Superficial ring. Superficial ring. If we look exactly to the superficial ring, it's here. Yes. And same as inverted V. Yes. Inverted V. It has 2 arms. two arms, lateral and medial. Am I right? It has two arms. Some fibers. What kind of fibers? Aponeurotic fibers. From the lateral arm reach to the medial arm. It's better I say there is two crura. Lateral and medial cruise. Okay? Lateral and medial is midline. Am I right? So some fibers, aponeurotic fibers from the lateral cruise attach these two to each other. So number 3, these reinforcements happen here. The name is reflected what? Ligament. So reflected ligament is some fibers of what? External aponeuros that connect two crura to each other. Medial cruise, lateral cruise to medial cruise. Yes, inverted V. It has two crura. Lateral cruise, medial cruise. It's joined like this. Yes? So, the posterior wall by conjoint tendon, Hesselbach ligament, and reflected ligament being reinforced. So, not easily, it may be when we cough, sneezing, or inside of abdominal cavity pressure being raised, it's not so easy that the intestine goes through this defect and reach to the inguinal canal. Any bulging through this canal, then herniation. It may be this herniation being direct or indirect. Now, I have a question. I would know which of you are intelligent enough to answer my question. Of course, it's back to your X knowledge. I think it may be back to the anatomy of the lower limbs, or it may be not. It's not depending on you being intelligent. I just joke. I tell you, okay? You as a surgeon, imagine, listen carefully. You as a surgeon, someone who referred to you for the surgery of the inguinal herniation. When you open the anterior wall of the abdomen, you face with a huge intestine that goes through this triangle, for example, I don't know, and destroying all of this part. It means it is not easily that you distinguish between direct or indirect because all the part of the posterior wall being destroyed. For example, as I mentioned, someone comes inside of this and destroyed even through the door. How you can find the difference between direct and indirect herniation? There is a landmark we are going to find. For example, if there be a cable, okay, a cable, a telephone cable or something else, if we have here and it destroyed by something that caused the door being destroyed too, you attention to this line, to this cable, and say because this cable is lateral and this part that he come inside, so it is direct. It being inside, we say indirect. Yes.
Hesselbach? Because of
Hesselbach completely destroyed. There isn't. Look here. There isn't any Hasselbach, any conjoint tendon. All of them destroyed.
Arcuate member.
No,
Median wall of
I told you we are going to find a marker
We can
that not being destroyed, being stable.
We can debate it on the inferior epigastric.
Yes. How you find this?
Yeah.
Oh.
The lateral is in the
Excellent.
can be medial.
Yes. Look here. Look here. We have here which artery? This
Inferior
one.
epigastric. Inferior.
What is this?
Artery.
Femoral. Above of this
inguinal external iliac.
external iliac. External iliac artery has two branch, just two branch, exactly above the inguinal ligament. One of them is here. One of them is here. Circumflex iliac deep, and this one is inferior epigastric. Inferior epigastric. Inferior epigastric is exactly here. Look here.
In the house.
Just exactly located behind of the Hasselbach. So, if you as a surgeon open the ball and check the inferior artery, attention and answer my question. The inferior artery like this is at the lateral of the mass. You say this herniation is direct or indirect?
Direct.
Indirect.
Indirect.
If the artery being medial than the mass, you say
Direct.
no. Completely just the opposite you're speaking. Look here, this is the artery, okay? This is the artery here. If the mass being lateral than this, then you say it's indirect. If the mass being medial, you say
Direct.
direct herniation. Direct, indirect. So the mark just back to the inferior epigastric artery. Inferior epigastric artery. Epigastric artery. So it's very important as a mark. Thank you for your attention and your observation.
Fish.
No. Again, I would like to know from one of yours as a volunteer that if someone referred to you and when you check the inguinal part of his, you find a mass, a bulging, exactly at the superficial ring. Exactly at the
Superficial.
imagine, look to the picture and imagine this. The first step in emergency room is this, that you should return back the herniated mass to the peritoneal cavity, to the abdominal cavity. So, it is your answer. Go there, stay there. Please tell us how in which way you try to return back the mass inside of the abdomen. Where is the mass? Show, look, please show. Yes, exactly is here. Yes.
Should I dissect it?
No, it's an emergency room, okay? The person referred to you, and then you
Yes, sir.
see, yes, you see that under the skin here there is a bulging like this. What do you do when you want to return back this to inside of that? You should push this bulging, this mass through the canal, that reducting to the abdominal cavity.
It's pushable?
Yes, it's easily, yes.
Not eating it.
Yes.
Without dissecting, without it.
No. Easily. The first step is reducing this back inside of that.
So I just need to push.
Just pushing posteriorly.
Uh-huh.
Is it possible that, for example, a mass is here, okay, I want to push it reach here, and then I push posterior. No. I want to conduct this mass that reach to here, and then you can see. So first, I push posteriorly because here this is the ring. Yes, I push posteriorly, then I push laterally, and then when it reach to the deep ring, push it posteriorly. Yes. Now, if the mass just being at the middle of the inguinal canal, you check that the mass is just here. What do you do for reducing this?
Directly posterior.
Lateral and posterior.
Still, posterior force is not useful. Why? Because it's not still at the level of the deep ring. First, you should through the superficial ring, push your finger, push it to the deep ring, and then by another hand pushing this. But by pushing posteriorly, yes, it may be, of course, in some parts you are right. If this be the direct herniation, it may be we push and it back to the origin part. But I think it's back. I suppose that it is indirect. I ask you because of this. Okay, I say at the middle or at the superficial ring, because if indirect, if it be a direct, it's directly reach to the and push. I mean, feel all the legs of the inguinal. But I say a bulging at the middle, at the superficial ring. Okay, and it is palpable that you can go through the superficial ring, through the skin, and then reach to the deep ring. Especially in old people, we can do this. Thank you. Any questions about this?
After the surgeon or the physician pushing it inside, does it get out again?
Yes, certainly.
So
And there is some accessory belt in pharmacy that they can prevent, but finally they must have surgery. And as it may be you hear about this, that in the most cases it's returnable. It's again back, because nowadays some surgeons, because they are very, I think they are very knowledgeable and they know all aspects of the inguinal canal. Easily they can do some surgery that completely inhibit again herniation.
by stitching the tendons or the whole muscles or the whole hernia?
I'm not a surgeon, so I think there is some special effort for the surgeon who they know. And in near future, you can learn this by your, the supervisor in the hospital and in surgery room. Okay? Inshallah. Huh? By parting study, just the anatomy is the base of all the science. Even though you be a nurse, a radiologist, or even though you be a physiotherapist, acupuncture therapist, everything. And in some cases, especially in the engineering, there are some engineers who are working in AI, and they are trying to invent some instrument for surgeon or some instrument for you that you can be being able to distinguish the problem that the patient faces with. So they must be very, very professional in anatomy. And if you want to be a good doctor, a good, not surgeon. Surgeon should be, must be aware about the anatomy. But even though, as a the physician who just listening to the patient, if he be expert in anatomy, physiology, and other basic science, I'm sure can be useful for the people, all kinds of the people. So it's very important. I beg you, please try hard. It's not necessary, even though if you say I'm studying 10 hours a day. It's so, it's not enough for a medical student. You should study harder than this. You should try to learn and repeat this by together, and then you can say you will be a good doctor. I hope. Again, for the last time, another question. Can you help me?